Okay, let's talk a bit about the RAAS. So, tell me about juxtaglomerular cells, how they're involved, and also about renal baroreceptors and renal sodium ion sensors. What's going on with those?
All right, let's dive into the renin-angiotensin-aldosterone system, RAS, and the roles of juxtaglomerular cells, renal baroreceptors, and renal sodium ion sensors. Juxtaglomerular, JG cells, found in the walls of the afferent arterioles near the glomerulus, act like pressure sensors and secrete renin when triggered. Renal baroreceptors, also in the afferent arterioles, detect low blood pressure or reduced effective circulating volume, signaling JG cells to release renin. Renal sodium ion sensors, part of the macula densa cells in the distal tubule, monitor sodium levels in the filtrate. Low sodium, indicating low filtration, also prompts JG cells to release renin. Renin then converts angiotensinogen to angiotensin 1, which becomes angiotensin 2 via ACE in the lungs. Angiotensin 2 constricts vessels, boosts ADH release, and stimulates aldosterone from the adrenal glands to retain sodium and water, raising blood volume and pressure. Together, JG cells, renal baroreceptors, and sodium sensors fine-tune RAS to maintain fluid balance. Want to dig deeper into angiotensin 2 effects or shift to acid-base balance?
So, what do these juxtaglomerular cells do then?
Juxtaglomerular cells, located in the walls of the afferent arterioles near the kidney's glomerulus, secrete renin when blood pressure or sodium levels drop. They send signals from renal baroreceptors detecting low pressure and macula densa cells sensing low sodium in the filtrate, triggering renin release to activate RAS, which raises blood volume and pressure. Want to explore renin's downstream effects or move to acid-base balance?
I see. Why don't we talk a bit about angiotensin 2? So, what's
All
going
right.
on? We've got tubular sodium ions transport in the kidney, and we've got aldosterone release. Explain this a bit to us. Explain how the hypothalamus is involved too.
All right, let's dive into tubular sodium ion transport, aldosterone, and the hypothalamus's role. The kidneys regulate sodium through tubular transport, mainly in the proximal tubule, loop of Henle, distal tubule, and collecting duct. Aldosterone, triggered by angiotensin 2 in the RAS, acts on the distal tubule and collecting duct, boosting sodium reabsorption via epithelial sodium channels, ENAC. This pulls sodium back into the blood, raising blood volume and pressure, while water follows, aiding fluid balance. The hypothalamus comes in when low effective circulating volume or high plasma osmolarity is detected by baroreceptors or osmoreceptors. It signals the pituitary to release ADH, which increases water reabsorption and indirectly supports RAS by responding to angiotensin 2, enhancing aldosterone release. Together, they fine-tune sodium and water to maintain homeostasis. Want to zoom in on ENAC or shift to acid-base balance?
No, that's so good. So, explain us the relationship between the effective circulating volume and the RAAS then. So, if we have a decrease in the effective circulating volume, this will activate the RAAS, and renal baroreceptors will notice it. So, is a decrease in ECV linked to a decrease in blood volume, which is linked to a decrease in blood pressure, basically? Is this a...
Yep, you're on the right track. A decrease in effective circulating volume, ECV, the blood volume perfusing tissues, directly triggers the RAS. When ECV drops, like in dehydration or bleeding, it often means less blood volume, which lowers blood pressure. Renal baroreceptors and the afferent arterioles sense this lower pressure and signal juxtaglomerular cells to release renin, kicking off RAS. Renin leads to angiotensin II, which constricts vessels and boosts aldosterone and ADH, conserving sodium and water to restore ECV and pressure. So, yeah, low ECV, low blood volume, and low blood pressure are tightly linked, and RAS steps in to fix it. Want to dig into angiotensin II's effects more, or shift to acid-base balance?
Well, that makes sense. Okay, so what's going on then? So decrease in effective circulating volume means that we have an increase in plasma osmolarity. So we have osmoreceptors in the hypothalamus, and I wonder why in the hypothalamus, that will release ADH. We want to stop peeing. We need the volume. We need it. Why do you think the collecting duct is the ideal place for ADH action?
The collecting duct is ideal for ADH action because it's the final segment of the nephron, giving the kidneys a last chance to fine-tune urine concentration and water reabsorption. ADH binds to V2 receptors here, inserting aquaporin 2 channels to reabsorb water, concentrating urine when plasma osmolarity is high or effective circulating volume is low. Its high permeability to urea and steep medullary osmotic gradient, set up by countercurrent multiplication, maximize water retention efficiently. Want to link this to RAS or acid-base balance?
That's so good. Let's talk about atrial natriuretic peptide. So atrial natriuretic peptide is the opposite of RAS, basically. So that would mean what if it's the opposite?
Atrial natriuretic peptide, ANP, is indeed a counterbalance to RAS. While RAS kicks in to conserve sodium and water when effective circulating volume, ECV, or blood pressure is low, ANP is released by the heart's atria when ECV or blood pressure is high, like in volume overload. ANP acts on the kidneys to increase sodium and water excretion by boosting glomerular filtration rate and inhibiting sodium reabsorption in the collecting duct, diluting urine.
Interesting. Okay, and lastly, what's going on with the environment? Like, why if we have extreme heat exposure, my kidney function will be worse?
All right, let's tackle why extreme heat exposure messes with kidney function. When you're in extreme heat, you sweat a lot, losing water and sodium, which drops your effective circulating volume and raises plasma osmolarity. This triggers ADH release to conserve water via aquaporin 2 in the collecting duct and activates RAS to retain sodium. But if dehydration gets severe, blood flow to the kidneys drops, stressing them. Over time, this can impair filtration, reduce urine output, and even cause acute kidney injury, especially if you're not rehydrating. Heat also spikes sympathetic activity, raising blood pressure, which can strain kidneys further. Stay hydrated to counter it. Want to wrap up with anything else, like acid-base balance?
That's all good. Okay, so let's talk a bit about acid-base balance now. Give us an introduction.
Let's dive into acid-base balance. The kidneys help maintain blood pH, ideally 7.35, 7.45, by regulating bicarbonate, HCO3- and hydrogen ions, H+. In the proximal tubule, kidneys reabsorb filtered bicarbonate and excrete H+ via transporters like NHE3. In the collecting duct, intercalated cells fine-tune this. Type A cells excrete H+ and reabsorb bicarbonate during acidosis, while type B cells do the opposite in alkalosis. This process works with the lungs, which control CO2 levels to buffer pH. Low pH, acidosis, ramps up H plus excretion. High pH, alkalosis, boosts bicarbonate excretion. Want to zoom in on intercalated cells or buffering systems?
So, explain us buffers and
All right, let's talk buffers and acid-base balance. Buffers are substances in blood, like bicarbonate, HCO3, phosphate, and proteins that resist pH changes by neutralizing excess hydrogen ions, H+, or hydroxide ions, OH+. The bicarbonate buffer system is key. CO2 from respiration combines with water to form carbonate acid, H2CO3, which splits into H+ and HCO3-, and accumulating hydrogen ions excretion and even protein sensitivities. This buffers with lungs, which control CO3-, while lungs adjust CO2 levels. In acidosis, buffers soak up H+, and kidneys excrete more. In alkalosis, buffers release H+, and kidneys dump HCO3. Want to dive into specific buffers or kidney mechanisms?
so kidneys have to do with non-volatile acids, so we didn't breathe them out or anything.
Exactly. Kidneys handle non-volatile acids, like lactic acid or keto acids, which can't be exhaled like CO2, a volatile acid managed by lungs. Kidneys excrete these acids by secreting H+ in the proximal tubule and collecting duct, while reabsorbing or generating bicarbonate to buffer blood pH. Type A intercalated cells in the collecting duct pump H+ into urine via H plus 2 ATPases, neutralizing acids, and create new HCO3- to send to the blood. This keeps pH steady despite daily acid loads from metabolism. Want to focus on H+ secretion or bicarbonate generation?
Let's talk a bit about the relationship between carbon dioxide and pH, and also let's talk about renal tubular acidosis.
All right, let's dive into the relationship between carbon dioxide and pH, then tackle renal tubular acidosis. CO2 in blood combines with water to form carbonate acid, H2CO3, which splits into hydrogen ions, H+, and bicarbonate, HCO3-. High CO2 levels, like in respiratory acidosis from poor lung function, increase H+, lowering blood pH. Low CO2, as in hyperventilation, reduces H+, raising pH, causing respiratory alkalosis. Kidneys adjust by tweaking HCO3- reabsorption or H+ excretion to stabilize pH. Renal tubular acidosis, RTA, is when kidneys fail to excrete H+ or reabsorb HCO3 properly, causing metabolic acidosis with normal lung function. Type 1, distal RTA, involves defective H+ secretion in the collecting duct, reducing acid excretion. Type 2, proximal RTA, is poor HCO3- reabsorption in the proximal tubule, losing bicarbonate in urine. Type 4 is linked to low aldosterone, impairing H+ and potassium excretion. Each type drops blood pH, and kidneys can't compensate well. Want to focus on a specific RTA type or CO2 buffering?
Summarize renal tubular acidosis in a sentence, and then let's talk about what's going on in the proximal tubule. So, like in acidemia, there's going to be increase in hydrogen ion secretion and increase in bicarbonate reabsorption from the proximal tubule, and explain why this is the case.
Renal tubular acidosis is a condition where kidneys fail to excrete hydrogen ions or reabsorbed bicarbonate properly, causing metabolic acidosis with normal lung function. In the proximal tubule during acetemia, low blood pH triggers increased hydrogen ion H plus secretion via the sodium hydrogen exchanger, NHE3, which pumps H plus into the urine. This drives more bicarbonate, HCO3 minus, reabsorption because H plus in the tubule reacts with filtered HCO3 minus to form carbonate acid, H2CO3, which breaks down into CO2 and water, allowing HCO3 minus to be reclaimed into the blood through carbonic anhydrase activity. This ramped up process compensates for acidemia by reducing urine pH and boosting blood HCO3 minus to stabilize pH. Want to dive deeper into proximal tubule mechanics or another acid-based topic?
Well,
Yo, we were just breaking.
so what's going on then in the distal tubule? And talk to me about intercalated cells. Explain to me what they are. Alpha intercalated, beta intercalated.
All right, let's dive into the distal tubule and intercalated cells. In the distal tubule and collecting duct, intercalated cells regulate acid-base balance. Alpha intercalated cells kick in during acidemia, secreting hydrogen ions, H+, into the urine via H+ ATPases and H+ K ATPases on the apical side, while generating bicarbonate HCO3- to send to the blood, countering low pH. Beta intercalated cells handle alkalemia, secreting HCO3- into the urine and reabsorbing H+ to lower blood pH. These cells work with principal cells in the collecting duct, which manage sodium and water under aldosterone and ADH. Intercalated cells adjust urine pH dynamically, ensuring blood pH stays 7.35, 7.45. Want to zoom in on H+ ATPase mechanics or link to acid-base disorders?